Hello everybody. Today we are going to discuss about antibiotic and fluid management in the acute pancreatitis. So the role of prophylactic antibiotics. Prophylaxis is the administration of antibiotic to patients who do not have clinical infection with the goal of preventing pancreatic infection. So according to the most recent published guidelines, the use of prophylactic antibiotic is not recommended in patients with predicted severe acute pancreatitis and necrotizing acute pancreatitis because their use is not associated with significant reduction in mortality or morbidity. Now about timing of administration. In 2008, Zhu and Kasai stated that timing of antibiotic prophylaxis is crucial. Early prophylactic antibiotic administration could reduce the incidence of infective pancreatic necrosis. The timing of antibiotic initiation is 72 hours from the symptom and 48 hours from hospital admission. The RCT's result shows that the mortality rate and the incidence of infective pancreatic necrosis were significantly reduced in patients who received antibiotic, confirming the original hypothesis that the timing of administration is critical. Now, role of PCT and CRP in predicting infective pancreatic necrosis. Several studies suggested that patients with the high level of C-reactive protein and the PCT, they are at increased risk of infective pancreatic necrosis. PCT serum measurement can be useful in predicting the likelihood of developing infected pancreatic necrosis and can help identify the patient who might benefit from severe early antibiotic therapy. Algorithms based on the PCT measurement have been shown to be effective in distinguishing bacterial sepsis from the SARS in variety of settings. Serial serum measurement of the PCT may be valuable for predicting severity of acute pancreatitis and the risk of developing infective pancreatic necrosis. Serum pancreatic PCT level may be helpful in reducing antibiotic use in patients with acute pancreatitis without causing more infection or harm. Similar to PCT, serial measurement of CRP during the course of severe acute pancreatitis are recommended to assess disease severity. More specifically, they found that increase of at least 90 mg per dl since admission or absolute value of 190 mg per dl after 48 hours predicted the severe form of acute pancreatitis with great accuracy. Now, the adverse event of acute antibiotic prophylaxis. Despite its possible clinical benefit, antibiotic prophylaxis is also correlated with the risk, including increased prevalence of multi-drug resistant bacteria, incidence of fungal infection among the other effects. So, fungal infection is the serious consequences of acute pancreatitis that is related to the increased morbidity and mortality. Another retrospective cohort study conducted in 2019 by Horibi et al. Found that antimicrobial prophylaxis was significantly associated with development of invasive pancreatic candidiasis. To date, routine antifungal prophylaxis is not recommended for preventing fungal infection in patients with severe acute pancreatitis, regardless of the use of antibiotic prophylaxis. Infected pancreatitis and antibiotic therapy. Several guidelines clearly recommended antibiotic for the treatment of infected severe acute pancreatitis. An important criteria for the use of antibiotic is the presence of infected pancreatic necrosis. It occurs in approximately 30% of patients with severe acute pancreatitis and is associated with significantly higher risk of death. Therefore, early detection and timely intervention with antibiotic are critical to improving patient outcome. This condition typically present with persistent fever, abdominal pain, and the systemic signs of sepsis. The diagnosis of infected pancreatic necrosis is usually confirmed by imaging studies such as CT or MRI, which demonstrate the presence of gas bubble or fluid collection within pancreas. Another condition that can occur in acute pancreatitis is infected peripancreatic fluid collection. Infected peripancreatic fluid collection are the sterile fluid collection that develop around the pancreas in response to the inflammatory process. However, in some cases, this collection can become infected with bacteria leading to abscess formation. Infected Peripancreatic fluid collection often presents with persistent persistent abdominal pain, localized tenderness, and signs of systemic inflammation. CT or MRI scan can also helpful in diagnosing infected peripancreatic fluid collection, as they can show presence of gas or thickened wall within the fluids collection. Historically, surgical intervention such as open necrosectomy was the primary treatment modality of infected pancreatic necrosis. However, this approach was associated with high morbidity and mortality rates. As a result, the less invasive technique have been explored, leading to the development of step-up approach, which entails a sequential treatment algorithm that starts with the conservative measure and gradually progresses to more invasive intervention if necessary. The treatment begins with the initial medical management, including fluid resuscitation, pain control, broad spectrum antibiotic to stabilize patient and control systemic complications. Serial imaging is crucial for monitoring disease progression and identifying potential complications. If patient fails to respond to conservative therapy or develops complication, the next step in approach is minimally invasive intervention, that is percutaneous catheter drainage under radiological guidance. It allows for the direct access to the necrotic collection, facilitating drainage and potentially reducing the risk of infection spread. The drainage catheter can be placed either transgastrically or transcutaneously, depending on the location of necrotic tissue. If the patient demonstrates a favorable response to the percutaneous drainage, further intervention may not be necessary. However, if there is persistent infection or inadequate drainage, the next step is endoscopic intervention. Endoscopic necrosectomy is the minimal invasive technique that allows for direct visualization and debridement of necrotic tissue. This approach utilizes the endoscopic ultrasound guidance to identify necrotic areas and deliver the therapeutic interventions such as tissue debridement and the cystogastrotomy. In cases where endoscopic intervention fails or is not feasible, the final step is the step-up approach in surgical intervention. This necrosectomy or minimal invasive surgical techniques such as video-assisted retroperitoneal debridement or laparoscopic approach. Surgical intervention is typically reserved for patients with extensive necrosis, multiple collection, and or those who fail to respond to less invasive measures. American Gastrological Association Institute guidelines state that carbapenem, quinolone, metronidazole, which are known to penetrate pancreatic necrosis, may be helpful in patients with infected necrosis and may be helpful to delay or sometimes avoid surgical intervention and reduce morbidity and mortality. The optimal duration of antibiotic therapy for infected acute pancreatitis depends on several factors, including extent of infection, clinical response, and radiological findings. In general, the minimum treatment duration of 14 days is recommended. However, in the absence of clear evidence, the decision to extend or discontinue antibiotics should be made on individual basis, taking into account the patient's clinical course and the resolution of infection. It should be noted that the use of antibiotic in a acute pancreatitis should be the part of comprehensive treatment strategy that include early restoration of hydration, pain control, nutritional support, and consideration of invasive measurements such as drainage of infected collection and necrosectomy if necessary. The spectrum of empirical antibiotic therapy include both aerobic and anaerobic gram-negative, gram-positive microorganisms. Fluoroquinolone and carbapenem, because of their ability to penetrate pancreatic parenchyma, are generally recommended for confirmed infective pancreatic necrosis. Aminoglycoside antibiotics in standard intravenous doses have low penetration ability into pancreatic tissue, so they are not first choice for infective pancreatic necrosis. Third generation acyluridopenicillin and cephalosporin have intermediate penetration capacity into pancreatic tissue and are effective against gram-negative organisms. Only piperacillin and tazobactam have shown efficacy against gram-positive bacteria and anaerobes. Quinolone and carbapenem both show good tissue penetration into pancreas and excellent anaerobic coverage. However, according to the World Society of Emergency Surgery guideline, quinolone are not recommended due to high rate of resistance worldwide and should only be used in patients allergic to beta-lactam agent. Carbapenem should always be optimized and used only in very critically ill patients due to increasing prevalence of carbapenem resistant Klebsiella pneumoniae. Metronidazole, whose bactericidal spectrum is almost exclusively directed against anaerobe, shows good penetration into pancreas. Of the various antibiotic used, only carbapenem prophylaxis shows trend towards efficacy, although without statistical significance, as shown in meta-analysis previously analyzed. So, extrapancreatic infection. Non-pancreatic infection mainly include pneumonia, bacteremia, central venous catheter infection, urinary tract infection, and cholangitis. In case of extrapancreatic infection, antibiotic therapy is already always recommended. Now about organism and the resistance pattern. In severe acute pancreatitis, pancreatic and peripancreatic necrosis is initially aseptic and may develop into infected necrosis contaminated with bacteria. Translocation of intestinal bacteria is facilitated by the intestinal barrier disruption, immunosuppression, and bacterial dysbiosis in combination. Most of the causative agent of pancreatic infection are gastrointestinal gram-negative bacteria resulting from disruption of intestinal flora and damage to the intestinal mucosa, as well as gram-positive bacteria, albeit less frequently, such as Staphylococcus aureus, Streptococcus faecalis, Enterococcus, anaerobes, and fungus have been found in the infected pancreatic necrosis. A recent study found that intestinal bacteria were the most common source of infection in patients with the acute pancreatitis. Lab data from blood, urine, sputum, abdominal fluid, and the catheter bile culture were corrected from 2089 patients with acute pancreatitis and MDR were determined. Intestinal flora accounts for 26.7% of total culture result, including blood culture and catheter culture. The microorganisms with highest rate of drug resistance were Coagulase negative Staphylococcus aureus, Enterococcus, and Enterococcus faecalis. Furthermore, four parameters, that is age, hemoglobin, length of hospital stay, and length of antibiotic administration, were found to be positively connected with disruption of distribution of multidrug resistance bacterial infection. So this is the diagram showing the bacterial translocation as a source of infection and pancreatic necrosis. Dysbiosis and intestinal barrier disruption causes intestinal bacteria to invade through the impaired intestinal barrier in a process known as bacterial translocation. The process exacerbates systemic inflammation and causes secondary infection. The abundance of harmful bacteria is significantly higher in acute pancreatitis patient, whereas abundance of bacteria that produces short-chain fatty acid, which are brought to have anti-inflammatory properties, significantly low. So, probiotic therapy in acute pancreatitis. In severe acute pancreatitis, pancreatic and peripancreatic necrosis is initially aseptic and may develop into infected necrosis if infected with intestinal bacteria. Several factors contribute to the development of bacterial translocation in acute pancreatitis. Firstly, the increased pancreatic duct pressure and obstruction characteristic of this condition may result in retrograde flow of pancreatic secretion into common bile duct and duodenum. Retrograde flow can facilitate migration of bacteria from the gut to the pancreatic tissue. Additionally, the inflammatory response triggered by the release of pancreatic enzyme can cause local tissue damage and compromise integrity of intestinal barrier. Pathogenic bacteria to translocate into systemic circulation and reach distant organs. Moreover, the release of inflammatory mediators such as interleukin and the TNF alpha can impair intestinal barrier function by disrupting tight junction and reducing the production of protective mucus. The translocated bacteria can elicit immune response, leading to release of pro-inflammatory cytokine and the activation of immune cells and amplification. Probiotics are defined as live organism that helps host health when given in sufficient amount. Studies conducted in animal model have provided encouraging results showing beneficial effect of probiotic administration in experimental models of acute pancreatitis. Unfortunately, randomized control trial conducted in patients have not confirmed this result. Baselink et al. Conducted multicenter randomized double-blind placebo-controlled trial that is Propatria, that is probiotic in pancreatitis trial, including 298 patients randomized to receive either probiotic combination or placebo. Surprisingly, results showed an increase in mortality in the group of patients treated with probiotic compared to the control group. Now about fluid administration in pancreas. Choice of fluid is ringer lactate solution. We have the recommendation is to avoid synthetic colloid. The in mild pancreatitis, we should give the approximately 3 liter of the fluid in 24 hours and 4 to 6 liter in 48 hours. If pancreatitis is moderate or severe pancreatitis, then 3 to 4 liter in 24 hours and 6 to 8 liter in 48 hours based on clinical and lab parameters. Now about rate of infusion in mild pancreatitis 1.5 ml per kg per hour with bolus of 10 ml per kg per hour in 1 to 2 hours with hypovolemia, blood urea nitrogen more than 25, hematocrit of more than 44, AKI, age less than 40 years and alcoholic etiology. In moderate to severe pancreatitis, fluid administration is 1.5 to 3 ml per kg per hour with bolus dose of 10 to 20 ml per kg per hour in 1 to 2 hours or higher in hypotension. Then monitoring goals, mean arterial pressure should be more than or equal to 65. Urine output should be more than or equal to 0.5 ml per kg per hour. Hematocrit should be less than 44. Blood urea nitrogen should be less than 25 at 12 to 24 hours. Invasive monitoring and dynamic parameter needed in ICU patient or cardio and duration is 24 to 48 hours and infusion can stop after 48 hours if oral feeding can be tolerated in mild pancreatitis. Thank you guys.